COPD. A very interesting topic because it's the only condition where actually the lung compliance increases. So in all the conditions where we read, there is a decrease in compliance. Here we get an increase in compliance. So there is a chronic inflammation of the airway by different pollutants. Okay, and if at bronchus it occurs or the bronchioles, it leads to the condition known as a chronic bronchitis. And if there is a chronic inflammatory at the terminal, just the respiratory bronchioles, which leads to breakage of the walls, because the respiratory bronchioles, the walls becomes thinner and thinner. This leads to a condition which leads to emphysema. So there is causes emphysema. The walls of alveoli break. So basically there are very high number of grapes. So actually the grape size increases but the number reduces. The surface area reduces. However, the gas exchange membrane, which is 1/3 of a micron where the exchange occurs, that remain intact. So gas exchange process is actually never hampered in a patient of COPD. So in a COPD, patient can normally breathe in because the inspiratory process is an active process. You have a diaphragm, you have a uh, uh, intercostal muscles. So because it's an active process, the patient can take in air, but when the time comes of a passive process, this obstruction cannot be overcome by the passive process, the pressure of the passive process. So what happens is the patient cannot breathe out. You can inhale but you cannot exhale. So it leads to something known as a hyperinflation of the lung. And if the patient tries to blow out with pressure, the terminal respiratory bronchioles collapse, which leads to air trapping. So you can understand this very simply. So when we try to suck in air when we try to suck in any liquid through a straw very fast, what happens is it collapsed. Okay, it gets collapsed like this. So exactly same thing happens if these patients try to blow out air using the help of an external intercostal muscles, because they want air, because that air which is trapped inside alveoli is having lesser oxygen and higher CO2, which is of no use. So eventually what happens, it causes air trapping. So what does the ABG of these patients look like if the patient happens to be it looks like a pH is low normal, CO2 is increased, oxygen will of course be decreased, and you will see bicarbonate increase. Why there is an increase in bicarbonate? Because this particular thing has happened because there is compensation. So there was a CO2 increase has led to known as a respiratory acidosis, and that is being compensated by the increase in bicarbonate by the kidneys, and that is why what you get is a pH is a low normal pH. So just in this COPD, so what do we get here is, this is where you are having the problem. So this is what you get is a chronic bronchitis. And if it occurs at the respiratory bronchioles, there is a collapsing which leads to a air trapping, and this can increase in the intrathoracic pressures as well, and which can cause something known as a hyperinflation. And this hyperinflation is actually bad, and that is why you see a large lung, you see a increase in the sizes of the intercostal spaces that increases. And even whenever there's hyperinflation, the hypertranslucency, so the black color of the lung is actually more enhanced in these patients. Now, since you all can see, there is something known as a air trapping here. Since you can see there is an air trapping, that means that there is some pressure present in the alveoli. So because there is some air, there is some pressure. Okay, there will be some pressure. Okay, so let's say this is an alveoli and let's consider this as a balloon. Okay, so if there is an air trapping we see, so let's say if you are trying to push a air in a balloon, so when there is no air, the first push when you give into the balloon, it's easy because the pressure inside is zero. So whatever pressure you give, it goes in very fast. Now when there is some air inside a balloon, what happens is, now when you try to push more air, how will the air go inside? The pressure should outside be more than the pressure inside. So let's consider if the pressure inside is plus 6, and so at least you require if the pressure inside is plus 5, so you at least require a pressure of plus 6. So then this air can go in, because now there is a positive pressure, there is a positive pressure of plus 1. Okay, so what happens in these patients, because now these patients are actually having some pressure inside the alveoli. So these alveoli has some pressure inside, because there is some air, because it has been trapped. So what happens when they try to inhale in air? So they need to inhale with lot of pressure. So they need a lot of inspiratory effort. This inspiratory effort, so let's say if the pressure is plus 5, they need at least of plus 6 of extra. So normally you don't require, because in a normal patient all this air goes out, so there is hardly a very minimal pressure. So but in these patients this is high, so they need to have more inspiratory effort to get inside this. Okay, this then only the gas exchange can occur, then only the air can move in. So this particular thing, because now what you call, even after exhalation this pressure is remaining, so that is why this is termed as auto, because this is an again automatically it is happening, and then again it is a end expiratory pressure, so that is why it is known as a auto PEEP. So to reduce the problem of these patients, this particular auto PEEP can be this auto PEEP can actually be you can actually see it on a ventilator. This is a ventilator setting as well. You can see it on the ventilator. There is a maneuver, you do it and you can get this auto PEEP. So what you do in these patients, you actually, because again the oxygen is less, these patients are less saturated, the oxygen is less, so what you do is you increase oxygenation by increasing PEEP. But how do you decide the PEEP? So what do you do to improve it? What you do, so you get the auto PEEP, you set the PEEP at, sorry, you set your PEEP at 70% of your auto PEEP. Now what does this mean? You set at 70% of auto PEEP. What does this mean is, in a simple terms, so let's consider there is some pressure of, let's say, plus 10. Okay, so if a pressure is plus 10, what will happen if they want to inhale? They need at least pressure of 11, so they need an extra effort, they need to put an effort of at least 11. Okay, then only the air will move in. So what you do, you put an PEEP of, let's say 70% of 10 will be 7. Okay, so here it is 10 inside. What you did, you put a PEEP here of plus 7. So what you did is, you have actually put some extra pressure by the help of a ventilator. What you did is, you put a pressure of plus 7. So now how much the patient has to do the effort? The patient require the effort of only 4 now. 7 plus 4 will be 11. So again now the air will move in, because this was imminent. So this 4, this is the kind of normal. So when we are kind of normally inhaling this much amount of pressure, or around 5 to 6 you can generate, but when it goes high then it becomes difficult, you need lot of effort. So this actually gives lot of relief to the patient. So that is why we set the PEEP based on auto PEEP levels, and we keep at this. So basically what does this do? This reduces the inspiratory effort. And majority time what we are, the patient is usually on a AC mode. So in a patient actually assess the breathing. So that's why we use this kind of a setting in a of a auto PEEP. Now again, now after we have discussed the auto PEEP concept, there are one more thing. So the problem is where in COPD? The problem is exhalation. Okay, so what exactly happens in this patient? The exhalation time increases a lot. Okay, so let's consider, so in a normal respiratory cycle or a normal respiratory rate, let's consider you have a respiratory rate of 12, so we have a respiratory cycle of 5 seconds. Okay, and because 60 divided by 12 is 5, so you have a respiratory cycle of 5 seconds, and the inspiratory phase is of around 1/3, and the expiratory phase is 2/3. So this is the 2/3 part. So this is in a normal patient. But what about these patients? The inspiratory phase remains the same, but what happens is these patients may require a very long time to exhale because the problem is exhalation. And no ventilator can actually help in exhalation because it's a passive process. It cannot suck in the air to take out extra air. So that effort has to be done by the patient itself. So again, when we see now this is a patient, so patient will have a low normal pH. The patient will have increase in CO2, patient will have decrease in oxygen and increase. So what do we think? Whenever there is increase in carbon dioxide, what we think? Okay, we increase the respiratory rate and a tidal volume, and in oxygen we'll increase the PEEP. Now here, the thing is, PEEP we have discussed. Okay, so we'll keep the PEEP around based on the auto PEEP levels. But what about the respiratory rate and the tidal volumes? Again, I told you we cannot increase the tidal volume too much because again that's a detrimental. But what about the respiratory rate? The problem with respiratory rate here is if you increase the respiratory rate, what will happen to the respiratory cycle? So let's say when we considered a normal of 12, the respiratory cycle was 5 seconds. But what we do if we keep it at 20, the respiratory cycle will become 3 seconds. So the patient will have lesser time for exhalation. And is this good? No, this is not at all good. Eventually, what will happen if you do this? This will eventually lead to breath stacking. Sorry. This will eventually lead to breath stacking. And you all know what does breath stacking do? It's actually pretty bad. So what you do basically, you never ever increase the respiratory rate. So now I'll discuss, there are few more features which are present on a ventilator which are used in these conditions. So one thing we do there's one feature in a ventilator. You can actually increase something known as a inspiratory flow rate. So inspiratory flow rate is how much when you inhale. So normally it is the flow is 60 liter of air per minute is a normal inspiratory flow rate in a normal patient. So what you do, instead of giving 60 liters per minute of flow, you give 150 liter per minute. And what does this do is that you provide more air. You provide more air. More air means more pressureful air because you still give the tidal volume same of 500 ml, but you give with a higher flow rate. And so whenever you give in a higher flow rate, what actually does, you are providing same 500 ml in lesser time. I'm not going into the mathematics that how does this actually do. So whenever you increase the inspiratory flow rate, what actually happens is you are giving, so you have a same amount of ml. So let's say if you have a 500 ml of air, and so that's, let's consider it to be 0.5 liter. So you are giving at a rate of 150 liter per minute. So when you divide 0.5 upon 150, it will come out something around, you are giving it in a lesser time. Of course, when you give it with a 60 liter per minute, so you are giving the same volume of air in a lesser time. So what does this basically does? What this does is, this inspiratory flow rate, what does this do? If you increase the inspiratory flow rate, your inspiratory phase, your IP, inspiratory phase reduces and your expiratory phase increases. So the patient will get the same air. So let's say if the patient was, if let's say the cycle was of 3 seconds. So initially if the patient was getting all the 500 ml air in 1 second and rest 2 seconds the patient was exhaling. So what you did, you actually delivered that same amount of air in 0.5 seconds. So now the patient can exhale in 2.5 seconds. So the patient gets more time for exhalation. And when the patient gets more time for exhalation, now there is an improvement in basically the ventilation because now there will not be a trapping. So the best thing what we do is we actually increase even up to 200 ml per minute also. So we increase the inspiratory flow rate and reduce the inspiratory phase and increase the expiratory phase of the period. And again, this is inspiratory flow rate again. This is done after decreasing. We actually reduce respiratory rate so that the respiratory cycle reduces, and then when we increase inspiratory flow rate, this actually expiratory phase goes a lot, this increases a lot. So let's say if you are having a 5-second cycle, so this 5-second cycle, after increasing inspiratory flow rate, you can actually deliver all the 500 of ml of air in, let's say, about 0.5 seconds, and you can have almost 4.5 second for each breath for exhalation. So this gives it gives a lot of comfort to the patient, because now the proper thing is happening. Now you have actually targeted. Okay, the problem is exhalation. Okay, so we'll give more time for exhalation. The problem is not inhalation. We'll give more pressure of inhalation, and the patient actually feels better. Similarly, in the newer ventilators, they have a feature of known as inspiratory expiratory ratio. So again, this is to decide that for how much. So let's say if you want 1/3, 2/3 is a normal. So 1/3 and 2/3. So you can actually reduce this. So you want, okay, I need this to be 1/6 and this to be 5/6. So that could be done. This becomes simple. And again, this particular setting is used only for COPD patients because they require the higher above exhalation, the expiratory phases. Again, initially this used to be calculated earlier. When you use inspiratory flow rate, you need to actually calculate how much time this is actually happening, but in a newer ventilator settings, you can actually set this with the help of a ratio as well. Just the last part, one more thing. So there are two things whenever you are on a ventilator, if a patient of a COPD is on a ventilator. So there are two things. So when you see this kind of an ABG, the thing is what do you decide, whether you want to correct the pH or you want to correct the PCO2 first, and of course the oxygenation. So now the thing is, these patients are chronic patients, and you can correct pH and CO2 if the patient is on a ventilator. But how do you decide what you want to do? So if you correct, these patients are on these patients have not seen carbon dioxide levels, the normal carbon dioxide levels, since years, and so the kidney is actually maintaining the bicarbonate levels since a long time, and that is maintaining. If you put these patients on a ventilator, and due to the help of a ventilator, you make this CO2 levels normal. Let's say you did it normally. Of course, when the CO2 levels will become normal, oxygen levels will become normal. This will become normal. So what will happen over a period of time, and when this becomes normal, the pH will of course become normal. What will happen? The bicarbonate levels will see, okay, now the CO2 levels are normal. What shall I do? What will I do? The problem, this bicarbonate will also comes down to normal. Okay, sorry. This also comes down to normal. Now what happens? This is when the patient is on a ventilator. Now what happens is, what now when you want to wean the patient, that is when the patient, if you are taking off the ventilator, now you know that's a chronic process, the inflammation has already been done, it's a progressive disease, the disease is already there. Now what will happen, as you take these patients out of the ventilator, again the CO2 level will increase, because that's what their bodies has been doing since long, the problem is still there. Of course the oxygen will decrease, and now you know what about the bicarbonate levels. So you all know that the bicarbonate levels, the kidney cannot immediately store the bicarbonate ions. It takes time. It takes 2 to 3 days or 4 days to eventually to compensate. So what happens is, this bicarbonate ion will remain kind of normal. So what will happen to the pH? pH will drastically go down. Sorry, this pH will drastically go down. So what do you get? What you basically get Now this condition is you get is a acute respiratory acidosis. So if you try to correct CO2, what happens is if you try to correct carbon dioxide too much, then what exactly happens is you can actually, once you wean these patients, the patient may actually land up in acute respiratory acidosis and can be detrimental. So what basically we do is we don't overcorrect the carbon dioxide. We want that this bicarbonate should remain around something around normal, and we let this pH to be something around low normal. We do not go, we keep it something around 7.3. We are very happy if we are getting something around 7.3. It's okay if we are not getting 7.35, but if we are getting something 7.3, we are kind of happy. So this is what the condition. The only thing I want to mention is do not overcorrect, just don't try to go beyond, because again, these patients, because it's a chronic condition, body has basically adapted to a higher carbon dioxide levels. So if you try to overcorrect these carbon dioxide levels to a normal physiology, now that becomes non-physiological for these patients. So once you take out these patients from ventilator, now that condition is highly non-physiological, and these patients may actually land up in a more serious trouble. So the last part, the vent setting in a COPD, we of course reduce the respiratory rate. We keep the tidal volume, the 7 to 8 ml per kg of idle body weight, which is normal. We increase the inspiratory flow rate, or you can say we increase basically the exhalation phase. And physiologically, we have mentioned our 60 liter per minute, we can go up to 150, 200. And we keep the PEEP at 70% of the auto PEEP, and I have mentioned that you can actually check a auto PEEP on a ventilator. And of course, when we correct these patients, we correct this patient on based on the, we do not overcorrect the carbon dioxide levels. We keep the pH something slightly towards on the low normal side. And if you see a breath stacking over on the flow loop curve in these patients, the best thing is you just disconnect these patients so that all the air, the patient, they just take out all the exhalation. So you just increase the exhalation. So if you see breath stacking in COPD, which is very common, so you just disconnect this patient for a few seconds and you reconnect the patients and the patient improves. So that's all for today. Hopefully you like the lecture. We'll be discussing something about the ABGs and the metabolic acidosis in the next part, and also we'll just mention the brief about the BiPAP. And at the end, we'll just discuss how you wean the patient off the ventilator, and that will be all about the mechanical ventilation. Hope you enjoyed the lecture, and thank you very much, and be safe.